Hello again and good afternoon. Thank you so much for joining us. My name is Marie Stuckey. I'm the Member Relations Specialist with the Maine Health Management Coalition, and we're excited to bring you the expertise today of Dr. Karen Murrell, who will be sharing information on creating a no-wait hospital. I am going to just start with a brief introduction about our organization for those who are tuned in and are unfamiliar with us, and also a little information on some of the activities that we have coming up so that our members may be aware of them and take advantage of them. I also want you to be aware that this presentation will be available on our member website in a few days or so that there's an archive available for your reference. If you have questions during the broadcast, feel free at any time to type them in the chat box at the bottom of your screen, and then we will present those questions to Dr. Murrell at the end of the presentation. So a little bit of information about the coalition. We are a multi-stakeholder but purchaser-led organization working collaboratively to improve the health throughout the state and maximize the value of healthcare for all dependents and in the state and all our members. Our vision is to lead the country in population health status, patient care experience, and reasonably priced per capita healthcare expenditures so that we have a healthy economic business climate here. We currently have over 70 members comprised of the 5 groups that you see: consumers, purchasers, plans, brokers, benefit consultants are grouped together, and then we have providers and affiliates. We accomplish our mission and vision through 5 key areas, of which data is the foundation of. We have the state's all-payer claims database. We also have a consumer website called Get Better Maine, where we publicly report on the outcome, safety, patient experience, and cost of different types of services, adult care, pediatrics, specialties, and so on. Our consumer engagement takes many forms where we support our employer members so that they can reach out to their employees, whether it's book clubs or competitive programs for health and wellness. In terms of benefit design, we're working with all the major health plans in the state to develop a new value-based insurance design that will reward on value instead of volume. And finally, we have a payment reform team who is working with our hospital systems and providers to set some new goals on reasonably priced care. Some information here on the opportunities to network and enjoy the benefits of membership. We have work group and committee meetings where people convene to make decisions about how healthcare reform will move forward in the state, and as a member, there are voting rights involved in some of those work groups. We hold special meetings and summits between stakeholders such as providers and employers at roundtables. And that third bullet I want to definitely emphasize, coming up in just a short while next month, we've got our big annual symposium co-hosted with the Maine Medical Association. Please be sure to contact us for information about registering for that. It's November 18th in Portland. Some other benefits of membership and opportunities to be involved and engaged are through some of our newsletters, training on value-based insurance design, free monthly webcasts for members such as this, some evidence-based policy training for policymakers, pilot programs, and special discounts for members as well. This is just a slide showing you about the upcoming symposium. And here's a quick view of our members. If you want to study it more in depth, you can certainly go to our website and it's there, or contact me for information on that if you're interested. And our member logos. Thanking our members very much for their support and participation. And the benefits of membership in a nutshell, I'll just breeze through a few of them, a high level. You know, our members have the ability to network with each other, to build their businesses, identify best practices for health. They have access to our outstanding data team. They can train their staff on educational events and resources, be guided to high quality, reasonably priced healthcare, brand their organization, and as we mentioned, some of the other benefits there, voting rights, webinars, and so on. We've also saved our members over $7.6 million in safety, according to the Leapfrog group. The hospital rating has been an A since we've been working on making improvements in the state. And so now I'm very happy to introduce you to Dr. Morel. She is currently the chair of emergency medicine for Kaiser Permanente, Northern California, where she leads 21 emergency departments. She's also assistant physician-in-chief over hospital operations, emergency medicine, psychiatry, and trauma, as well as process improvement and optimization at Kaiser South Sacramento. Dr. Morel's extensive experience in hospital and ED management spans over 30 years. In her current role, she's focused on innovative approaches to patient flow in both the emergency department and inpatient hospital. Using lean methodology, changes in departmental flow resulted in markedly decreased time to physician and length of stay with decreased left without being seen rates. Dr. Morel is also currently a leader on the hospital throughput committee, where queuing methodology is being used to impact the patient length of stay and to reliably predict staffing needs. Dr. Morel has presented both nationally and internationally. She teaches lean methodology to create a no-wait ED and has published articles to share her expertise. She is a graduate from the University of Tennessee's Physician Executive MBA program. And now I'm very pleased to present you with Dr. Morel. We're just going to switch over to her slide deck.
Hi, everyone. Good morning. Can you hear me okay?
We hear you great.
Okay, great. Well, thank you so much for the opportunity to talk to you guys, and we're across the country from you. And I'm originally from Chicago. I'm transplanted to California, but I'm very happy about the Cubs win last night, so I just have to say that at the beginning. But I've been in emergency medicine my whole life. My very first job when I was attending the University of Chicago was as a clerk in the emergency department, and then I've kind of gone through and I've done almost every role. I was a tech in the ER, then I went on to become a nurse, and then became a physician. And throughout all of that time, I just thought waits were just part of emergency medicine and part of hospitals. I didn't think there was any way to make it better. And I happened to read a blurb in my alumni newspaper about this Lean for Healthcare class, and I took it, and I can honestly say that it changed the way I look at everything. And so what I'm going to talk to you about today is kind of our journey over the last 6 or 7 years. So it's going to be a lot of different things, but it's just the way that we went from being awful to really being one of the top ERs in the country. So could you advance for me? So again, in the past we were terrible. We had waits in our lobby of up to 12 hours. People were sitting there just trying to get in to see a physician. And everybody knows who works in emergency medicine that you never know who the sick person is in your lobby. So we were really afraid. And just a little bit about my ER. It's so interesting to hear you guys talk about becoming an accountable care organization. That's really what Kaiser Permanente is. It's kind of this integrated health system where we're rewarded for people staying well. There's no financial benefit at all to admit patients, and we try and really focus on the outpatient world and getting them better. So about our emergency department, we're the busiest ER in Sacramento. We're a Kaiser facility, but we really have become the county hospital for our area. We're about 40% Medi-Cal and uninsured in our ER. We're a level 2 trauma center. We teach the residents, and we're on pace for 120,000 visits this year. And just so you know, when I was chief here about 7 years ago, we were only seeing 67,000. So we've seen almost a doubling of our ER visits over the last years. And we're up 27% since January, year over year. So really trying to eliminate waits and getting good flow is really like chasing a moving train. And in the hospital, again, we're this trauma center. And obviously those patients can stay a lot longer than the traditional patient. We're a STEMI receiving center, a stroke center, and a center of excellence for total joints. And our challenge on the inpatient side is that we only have 146 inpatient beds. So imagine all of these things feeding into this hospital, with only 140 beds. And so obviously we're very space constrained. In our ER, we only have 49 ER bays, and we lose 3 for trauma. We have 4 that are permanently dedicated to psychiatry. And so that's over 2,500 patients per ED bay. And what we normally see and what is recommended is 1,500 to 1,800. And on the hospital side, again, we have 100 here, just a little over 140 beds for all of these ER visits coming through. And so I'm just going to show you where we came from and where we went through. And then as we go on and at the end, maybe if you have any questions, or please feel free to email me in the future if you have any questions. So could you advance this one? So before we really were terrible, we had 450 hours of ambulance diversion annually. Our left without being seen rates were 6.6, but as all of you know, or at least in our place, winter is terrible, and we would often go up to 12 to 20% left without being treatment. Our door to doctor was 55 minutes on average, but again, when you look at an average, there's usually a very long tail, and it could go up to many, many hours. And our total time in the ER was 4.5 hours for discharged patients and 8 hours for admitted patients. But what killed us was this wide variability day to day, and obviously much longer time some days. And for me as a doctor, I might work a 12-hour shift, and I would only see 8 patients the entire day when there were 30 or more in the waiting room, just because our flow was so terrible. We were frustrated, we were complaining, and obviously you have to order tests if somebody's been waiting 12 hours. It's really hard to tell someone they have a cold after they've been sitting in your waiting room for 5 or 6 hours. And everyone was angry, the staff was angry, it was just total chaos. And our patients waits of 5 to 6 hours to see a doctor. Every single night there were 30 to 40 patients in the waiting room, and I would often get calls as the chief just to see if I could get the patients in quicker. So we knew something bad was coming. We knew we were going to try and become the trauma center for the county. There was none on the south side of Sacramento, and we wanted to do it. Look, our volume's almost doubling in those years, and our county in Sacramento basically closed the doors to the crisis unit in 2009, just to add insult to injury. And so we lost all of our crisis unit beds and half of the inpatient psychiatric beds. So our ER often became filled with over half of our beds full of psychiatric patients. And we have those continued hospital space constraints. So I was sitting there in the middle of all this chaos and trying to figure out what to do. This was right across the street from us. It really could have been us, and it was such a scary story. And this was kind of the beginning of starting to really think, we want this to never happen in our ER, and how can we make sure it's not going to do it? And so this is the start of our story. So right now, our time to physician is 19 minutes, and it's very consistent. Our left without being seen is 0.4%, and it's been that way for probably 5 years. And our diversion hours are none, and our length of stays are markedly down, 43 minutes. If you come in with a cut or need sutures or anything like that, you're going to be in and out in under 40 minutes. Discharge patients are 2 hours and 9 minutes. We rarely hold inpatients, and our hospital length of stay is just over 3 days. So we're working all the time to create capacity, but it's been a long road, and here's how we did it. So in our ER, 80% of our patients are going to be out of the ER in under 4 hours, and 55% in under 2 hours. And what we've learned over time is that decreasing length of stay creates capacity. And just to bring it back, this is why I'm so happy we did all the work. This is the reason for everything. So in March 2011, a little girl came to our ER with vomiting and diarrhea, no fever, nothing abnormal on her vital signs. And in our old ER, she easily would have waited 5 or 6 hours in the winter. But she was brought in right away. And the ER doctor, Dr. Jeremy Cook, just said, boy, she just does not look right. He did an LP, and she had more than 7,000 white cells, and she had meningococcal meningitis. So, and this is what he gets every single year from this mom. And it says, Dr. Cook just thought we'd send you an update. Thanks to you, Savannah beat meningitis 100%. She went last May for her year-end checkup, and she's perfect. And I love the way she says at the end, without you, my life could have been very different. And so this is how we inspire our staff. That's what we do. So again, here's a recap of where we were and where we went to and how did we do it. You can advance, please. Thanks. So just again about Kaiser, and we are this prepaid integrated health system. We don't like to admit patients financially. We have similar acuity to other ERs and hospitals, but good follow-up that we have and available testing is a real advantage for us. So we would rarely admit stable chest pain, atrial fibrillation we're sending home now, often after cardioversion, TIAs, DVTs, now low-risk PEs, diverticulitis, those often just go home. So not only do we diagnose our patients, we treat as many as possible to send them home. And we've really come to realize that being in the hospital isn't necessarily what patients want, and actually our outcomes are often better having patients going home. So we did a comparison study, and we really have the same acuity as most level 2 trauma centers, but because of everything that we have in place, our admission percentage is 11%, and that's why we can have 146 beds and see 120,000 patients. That's what saves us. So you can see only 10% of our chest pain patients are admitted. That doesn't mean we don't do testing. That doesn't mean we don't make sure that they're safe, but we don't always just go straight up to admission. So how do you even start a program like this? And what we started with is looking at every process and then creating this culture. I'm so proud of our nurses. If we have more than 4 or 5 people waiting in the waiting room, they're starting to freak out, and we're going to find a way to make beds, and we're going to move things around and do whatever it takes to have our patients. And as far as process goes, we look at everything with a critical eye, and we want every process to be better for the patient, but easier for the people doing the work. So we have a lot of things in medicine that are legacy kind of behaviors and flows that we think we have to do, but a lot of it is non-value added, both for the patient and for the people doing the work. So over time, I've learned that these are the steps to setting up a program. You want a really strong leader who sets this vision for the staff. If you come to my ER tomorrow, you're going to see a sign up on the wall that says, "We want to be the best emergency department in America." And we said that when we were the worst. That was our vision, though, and we've been working on this for all these years. Again, we look at every single process critically, and we create things that are better for patients and easier for staff, with the staff developing the program. So we have a flow team in our emergency room, and across Northern California, I've charged every emergency department chief to have a flow team that has clerks, techs, nurses, doctors, and administrators on it, so that they can really make this improvement, but do it with the people doing the work who are the real experts. I strongly believe in continuous improvement. We never sit back on our laurels. We're still trying to improve things today, and having open data with clear metrics, and then having a lot of fun with it too. I mean, this group was really fun. We do a lot of kind of crazy things at these. We have these things called Kaizen events that are 1-day to 5-day process improvement events, and it's really become team building too, and that's how you start to get that culture that you need for this kind of work. So we really work to empower everybody to own the change, and everybody. When people come to walk around our ER hospital, everybody's talking the same language, and that's been over time. I told all of my new physicians, if you don't like change, you probably don't want to work here, because things are going to be changing all the time to again, take a hold of that moving train. I gave all my physicians these leadership books, and I challenged them to do projects that would help the department. I did pay out of my departmental budget, just in case you have questions about that, for those projects, but way more financially, I got more financial rewards out of that. And it's similar to Toyota. If you have some books that you might want to look at are the Toyota Way, and also a book called The Goal, where you really look at things in a different way. They got 80,000 suggestions from employees, and they implemented 99% of them. Sometimes that's easier said than done, though. One other thing I've learned over time is that I rarely take no for an answer, and if I haven't asked for something at least 30 times, I probably haven't even started yet. So here are 2 key principles. Absolutely. I never put anything in place, and please think about this critically. A lot of hospitals I've seen have this reaction when things go wrong, that they add they overlay additional kind of flows on top of other legacy work that they've done, but you want everything to push toward decreasing length of stay. So even a few minutes in service time, even a few minutes in an ER stay, even 2 hours in a hospital stay make a huge impact when you're living on the high end of this utilization curve that I'll show you. And decreasing length of stay is the most key metric for making process improvement. So most hospitals now live on this, on the right-hand side of this slide, that with utilizations way over 80%. And I don't know what your hospital utilization is, but when you live on that curve, if you add something additional onto that, it creates exponential increases in weights. So think about it. If you don't think of anything else from this talk, think about if you add just a few minutes on that curve on the right, you exponentially increase your wait times for the other patients. So always think of trying to push that curve to the left. And these are some of the things that we did to improve flow in our ER and in our hospital. We developed a really streamlined rapid care. We assign our patients in the emergency room in the waiting room. So we have this ownership now. It's called team assignment. We have a robust observation unit. We staff for our volumes. We have open data. In the hospital side, we have this rapid surgical unit, hospital partnership and teamwork, and then OR smoothing. So as you can see, everything is about this process and culture that I was talking about before. So I'm going to start with just talking about ER flow, and then we'll talk a little bit about hospital flow. And when you're thinking about ER flow, think about it in 3 ways. You think about it as door to doctor, doctor to disposition, and disposition to departure. So when you kind of bucket things that way, it's helpful. And then always look at your low-hanging fruit first. Pick the easiest project first. So for us, that was our rapid care in the front. And then also in this way, we looked at staffing for volumes and then our assignment system. So before we had these changes, this is what our emergency department looked like. A patient would arrive. We had this thing called a medical screening exam. We used to triage patients to clinics if they had a low acuity problem. So we had this process that took about 19 minutes to do this medical screening exam by a nurse. Then patients would go sit in the waiting room. And just imagine if we had 10 arrivals an hour and we had one person doing a medical screening exam that took 19 minutes. You can just think they can handle 3 patients an hour, 10 are arriving. So it would often be a whole waiting room of people who hadn't been seen by anyone. It was really ridiculous. So the very first thing we did was look at this initial arrival process, and we got rid of almost everything and turned it into a 2-minute process where the only thing we're trying to do is figure out where the patients go. Is it low acuity or high acuity? There's really no reason to have a long triage process ever. So and then as far as the doctors in the back, my rooms weren't close to each other. I could have rooms across our ER is about as big as a football field, and I could have patients on both ends of the ER. I remember once I was sitting on one side and a nurse was really dutifully recording a blood pressure of 70, but I was so far away and she never reached out to me. And so it really created these kind of problems medically as well as problems walking and poor communication, a lot of things. The other thing is our flow was controlled by a single kind of charge nurse who really became a bottleneck in the ER, and she really had to open up these kind of golden doors, and occasionally a patient would come through. So this is what led to these 30 or more patients in the waiting room at 11 p.m. And it also meant we had these wide variations in length of stay by hour of the day. So when you have a really well-run ER, your length of stay across the 24 hours is almost even. So the first thing we did, we set a vision with our staff that our patients don't wait. We're going to do whatever it takes. And we're going to figure this out. Again, we said we wanted to be this best ER in America. It was just a vision at that time. And we found that really taking risks and asking forgiveness later, paying a few hours of time for staff in these kind of Kaizen events, which are rapid improvement events, pay off in spades later, and small tests of change. that's people laugh at me because I'm always saying, oh, let's just try it for a week, let's try it for a day, let's try it for a month. But everyone then thinks their voice is heard, and then you can make these changes that stick. So just starting in the front door triage, it's such a part of our bread and butter as emergency physicians, but it's really non-value added. There should never, ever be a time when a doctor is sitting idle and a patient is sitting out there getting triaged. So the only time you should use it is if you are too busy, if you have to sort, if you have to have people waiting. So eliminate it if you can. And then what we found is if you can directly pull into your area, if you guessed wrong, no problem. Just shift the patient. If I pull in an ankle pain and I'm in the low acuity area and I see it's a big diabetic ulcer, no pain, no gain, I brought him in quickly and I shift him to someone else. So we have 3 flow areas in our ER, and that's because of our high volume. So we have 3, low acuity area, a mid acuity area, and a high acuity area. And the reason to segment like that is because we have really well-defined processes that decrease the length of stay. Again, I'm going to push this thing all the time that decreasing length of stay is the most important thing. But we did find that 90% of the time the first impression is the right one. So I'm sure a lot of you have an urgent care, and so why did our physician in triage rapid care help us so much? And this was our very first project. And we start to think about low acuity patients. Instead of doing that 19-question medical screening exam, now we're triaging patients to home. And we think about in the 19 minutes we took for that former triage, we can actually take care of them, get them their prescriptions, and get them in and out. So about 30% of our patients fit in this category after healthcare reform. We still have a lot of lack of primary care, and so people are still coming to the emergency room for their care. So it started thinking in a new way. This is one of our nurse managers. It's not the best picture, but you can see in our rapid care area, he's holding a huge pile of Foley catheters. And when do we ever put a Foley in rapid care? It was just pretty absurd. So we really looked at this area. We made it a very small, constrained area. Now we're sitting with our nurse as a doctor-nurse team or a PA nurse team, and it's really become this amazing teamwork. We have very uniform stocking, and our goal is to have just one contact with the patient as much as possible. If they don't need any testing, I want them to come in, I'll talk to them, see them, print out their prescriptions, and then send them out without having to pull them back in the room, and no movement by me, no movement by anybody else. Okay. But this is what it looked like when it started. I guess it looks like it was in 2007 when I very first started doing this. And you can see it wasn't formal at all. It was like these, I guess I thought on the right, if I put these funny stickers, maybe people would like it better. But I had, I was usually pretty well liked, but I think I used all my political capital, 100% on this project because people hated it when it started. And I have found that every project is like 90 days of pain, that people don't like change by nature, myself included, and you really have to stick with it for 90 days before you know it works or not. So. And we even said this thing that no patient was ever going to go back to the waiting room, and we're just going to see everybody first. We want to have this continuous forward flow. And I had this line in the back of my ER that was as long as a football field, and it was a disaster. So this just, it shows that you have to make changes as you move along. You have to be flexible, and you have to figure things out. And the other thing is, you can't just say, go try it. You have to be living in that area. I think myself and my nurse manager basically lived in that area for the first 30 days. So right now, if we're doing low acuity in our ER, the patient will just arrive. We'll triage only if there are delays, and then they'll be seen really rapidly. And we got these immediate results in our left without being seen rates that have never gone back. So I'm going to show you a little video that just shows what the low acuity flow looks like. And one of our psychiatrists, his relatives work for MTV, so they made me this little video. Can you guys hear that? I can't hear that one.
We hear it.
I think I hurt my wrist, and I think I need to see a doctor.
Oh, absolutely. Let's get you checked in first. Can I have your first name?
Christina.
And your last name?
It's Lee, L-E-E.
And your date of birth?
July 24th, 1984.
All right. Can you go ahead and sign on the keypad there? Great. Put this around your good wrist.
Okay, the doctor will see you now.
Oh, so fast? There's no wait?
No, we only want the patient to tell their story once here to the doctor and the nurse taking care of them. We try to avoid triage here whenever we can.
Wow, that sounds great.
Just this way.
Thank you.
Christina, why don't you come on in and take a seat?
Hi, Christina. My name is Dr. John, and this is your nurse, Cameron. We're the medical team taking care of you today. What happened?
I was snowboarding. I just fell on my wrist.
Oh, I'm so sorry to hear that. Let's take a look at your wrist. Can you show me where it hurts?
All over here.
Do you mind if I examine it?
No, please.
I'm just going to feel starting from your elbow down. Let me know where it hurts the most, okay?
Yeah, that hurts.
Can you bend your wrist for me?
Kind of.
How about down here? Can you wiggle your fingers?
Yes.
Can you squeeze my hand? Okay. Well, I'm concerned about the area of pain. I'd like to get an x-ray just to be sure.
Okay.
Christina, how would you rate your pain from 1 to 10, with 10 being the worst pain that you can imagine?
I'd say it's 5. I mean, it hurts pretty bad.
We can get you something for pain. I looked in your chart. It says you have no allergies. Is that correct?
Yeah, no allergies.
Great. Why don't you follow me? We can get you something for your pain on the way to x-ray.
Sure. Thanks so much. This was so much faster and easier than I thought it would be.
Oh, great. I'm so glad we could help you out. Hope you feel better.
Thanks. Take care.
Yeah, bye.
Okay, well, I apologize for the choppiness of that video, but those are our ER doctors there doing the process. But that's really what it looks like, and you can see we've eliminated almost every unnecessary step in it. So it really is this doctor, nurse, patient all sitting together, working toward rapid discharge, minimal movement by everyone. You can advance, please. And this is just a picture, real life. And we looked at everything. It even has lean printing. That's a prescription printer. That's our printers for discharge. There's no reason. And then at the end, before they leave, they actually get their discharge. They go to a discharge lounge and have their copay collected, et cetera. And we do take vital signs. That was a little bit glamorized, but we can move on. But this little process really made us think that about looking at everything in our hospital and our ER in the same way. As far as staffing goes, we really didn't match our staffing to demand. And I have seen some places, hopefully not you guys, where you have very flat staffing and you have almost the same staffing at 10 a.m. as you have at 3 a.m. Could you advance? So you can see that was 2008. We were super flat, and that's just what I was talking about. Those are our arrivals by hour of the day on the right and the staffing on the left. And afterwards, you can see it pretty much matches the arrival flow. So the reason it looks so flat on the PM shift is we live in the land of nursing ratios, and we have to have lunch breaks, et cetera. And for physicians, you could see the blue line are is the physician staffing, and the magenta kind of lines are the arrivals. And you could see every day starting at 7 a.m. we would get behind. We couldn't see the patients coming in, and so it led to this kind of delay in care throughout the entire day. So all we did was just shift one of the shifts a few hours earlier, and all of a sudden we started the day much more caught up. And we look at the staffing all the time, almost monthly right now. Yeah, with healthcare reform, we were seeing 120, and now we're seeing like 300, probably 400 a day in the winter. So we had these good results, but we still had some long waits, and our concern was those were the higher acuity patients waiting. So how are we going to replicate this teamwork, and who owns the waiting room? This is a great movie, by the way, if you get a chance. So what we do now is we assign our patients to a color-coded team in the ER on arrival. So as soon as they walk in, instead of that long football field distance between us, we have teams in our back. We have color-coded teams, and every doctor has two nurses and a tech working with them. And this created this ownership for the patients and decreased our time to doctors. So you're assigned to really a small ER, and these doctors own this small part of the ER, and they manage it. And the expectation is you see the patients assigned to you before you go home. We do taper people down at the end, so most people are actually getting out earlier. But it was just this huge shift to us that now we're owning the waiting room. It wasn't just like one of our doctors said, oh, those poor patients in the waiting room. Now we're like, that's my poor patient in the waiting room. I'm going to do whatever it takes to bring them in. And the other thing that we do is we don't have a charge nurse who's controlling flow. We have a charge nurse that's controlling discharge at the end. So the incoming flow is controlled by the teams, and on the back end is our charge nurse focus on that. So again, every team gets 6 rooms and 2 hallway rooms. You manage your own area. We left our code rooms flexible for any team. And most physicians really loved it because they were loaded with 3 patients initially and then tapered at the end, so everybody was home on time. The other thing is I've worked with a lot of places that are fee-for-service, and actually with this flow model you can actually see more patients than you're currently seeing. But it does even out the workload, especially for nursing. We don't often think of nursing workload, and we don't even have to think about it on this because the patients are round robin to each of the teams. And this just shows, again, how close everything is. Minimal movement. And everybody, we help each other. If one team is slaughtered and gets accidentally 3 codes at once, all the teams go together and help each other out. That's part of the culture that I'm talking about. So now we're going to talk about doctor to disposition. So we also have this is our mid-acuity area, and this works super well. This is for level 3 patients. Almost every ER has about 50% of their patients or more are level 3s. So this is creating capacity. We're putting more and more patients through this area, and they do fantastically well and like it more. So let me tell you about it. So the key points are, in this area, our goal is to diagnose people and figure out what's wrong with them. The bread and butter of this is low acuity abdominal pain. But we have found that using PO meds instead of IV meds work just as well, and patients actually like it better. It's this culture that we think we have to start an IV on everyone and draw the labs in that way. We're actually finding that that's a big nursing workload drain, and it doesn't really add a lot of value. So we never change our diagnostics. We partnered with radiology. We eliminated most contrast for things like appendicitis. We use a phlebotomist now whenever possible to draw the labs, and that frees up our nurse again to do nursing work. And we have a results waiting room for patients who need testing. If they need more treatment or anything, we partner with the main ED to move them through. The goal of these 2 areas, low and mid, is to be the flow area for the department. So they can't clog up. They aren't the safety valve if we're full, and they just continuously discharge patients out so that our waiting room doesn't stay full. Could you advance? Yeah. And what we found is that patients with the same chief complaint had more than an hour cut off their length of stay. So abdominal pain, we're getting CTs, we're getting ultrasounds, we're getting lab tests. We know what's wrong with them. They're diagnosed, they're treated in under 2 hours. If it ends up being appendicitis, that's great. We diagnose them quickly. We call the OR, then we start the IV, we move them to the back. But that ends up being probably less than 5% of the patients. You'd be surprised. And this is who goes there. Abdominal pain, back pain, chest pain, young, DVT rule-outs, flank pain, headaches, and we've eliminated almost all narcotics with our headaches as well, pelvic pain, pediatric fever, and gastroenteritis. So we use open data. We met as a group. I went down to a department store and I saw they had open data on all of their employees. I was like, if we're doing all this important work, why don't we know how we're doing? So we met together and decided our goals. we think about low acuity, we think of our patients in terms of 1 hour, 2 hours, 3 hours, and admission. So 1 hour is the rapid care, 2 hours is this kind of level 3 area, 3 hours is the higher acuity, and 4 hours is really the admissions. But that doesn't mean we try and push people out if they aren't ready. Our goal is to eliminate the non-value added parts of it, keep the value added. If someone needs treatment for 6, 7, 8 hours, no problem, we keep them. But if in general, we're going to try and set these goals. So we worked on our systems issues too, so the doctors could reach the goal without any heroics. Again, better for patients and for the people doing the work. At our staff meeting, we discuss efficiency tips, we share best practices, we allow people to shadow the faster people, and we balance our efficiency metrics with quality and patient satisfaction. Could you go back one more? So this is, I actually paired up with some researchers from Harvard, and they actually, I always knew open data was important, but they actually did a really deep dive, and we found that this open data decreased length of stay by 10%, and the people who were most impacted were the people who were slower. The faster ones stayed fast, the slower ones got much better, and it was really interesting to have this verified by somebody who really understands statistics way better than I do. So this is a paper that we have that's coming out. And we don't choose our metrics at random. They're chosen to create capacity. Again, decreasing length of stay creates capacity. So if you have somebody in the bed for 2 hours versus 4 hours, you can see twice as many patients, right? So you've really almost doubled the capacity of your ER. So this is posted in our break room. This is what it looks like. And you can look with open data, our standard deviation narrowed and our length of stay is down. In left is where we started, and you can see everybody's name is right down there, top to bottom. We looked at it at staff meeting, and our goal was 1 hour. And you can see when we started, almost nobody was meeting the metric, and we had a pretty wide standard deviation. Now look in February 2014, look where we are now. See the red line is the 1 hour goal, and we have a lot of people who are down to 30 minutes. And the people who are at the bottom, we don't punish them or anything because most of them are night shift workers when the area is closed, so we recognize the systems drive the performance. And I think one of my proudest times was when someone who was really our slowest people was #1 on this chart, and it was because the systems drove them there. So no pushback, doctors want more data, and we are looking to add nursing and tech data too. And you could just see by ESI level what it did to length of stay, it just drove it down. Dispo to departure. So we have a really robust observation unit, and that's now we're starting to look at the inpatient side. And because of our low admission rate, our observation unit really has a little bit higher acuity. We have an 8-bed unit that we use, and it's staffed with ER doctors and nurses, and we focus on flow. So we're able to do more testing. We put a lot of our GI bleeds there, almost all chest pain, TIA, syncope, pylos, transfusion dialysis. Sometimes we do mild DKA, sepsis, asthma. But it's all protocolized and works really streamlined and well. The GI doctors say they could see twice as many patients. So this just shows a case for a GI bleed. The patient arrives in the ER with a lower GI complaint, vitals are checked, the I-stat hemoglobin's done, and the person's sent up to the CDA. If it's a message is left for them, we standardized our bowel prep, we transfuse, and then they're scoped in the morning in a procedure room in the CDA. So there's minimal movement, again, of the patients. The doctors are more productive, and 75% are discharged home after recovery. So look how we eliminated so many steps, movement to the floor, repeat labs, doing all these things. So it's just a study for a lean methodology. We really have this happy doctor, that's our chief of GI on the left, and the happy patient because, again, patients don't like to be in the hospital if they don't need to be. And if the bleeding's controlled and they're ready to go, that's it. And we've been doing this for some years with really good outcomes. And these are our patient satisfaction scores. The purple scores are for the patients who are seen in the observation unit versus the regular ER. They just love it. So many hospitals have this kind of war between ER and inpatient, and we try and look at the long view of the patient here. From the arrival in the ER all the way through the hospital, how can we help each other? But it was a long road to get there. Now we really feel like we have this real true partnership between the two. I'm over hospital operations too, and it really is. We may squabble like siblings, but in general we have the same goal, again, the same leadership, vision, looking at process. So we started with this vision. We wanted to eliminate boarding in both, I put ER, but it's really ER and PACU. And I found a partner on the floor who just wanted to make things better. There were so many times we were just going to all these meetings and not much was accomplished in between. So we decided to sponsor these series of these Kaizen events, these process improvement events with both ER and floor participation. It was interesting. They often never talked to each other. So we have a bed hub. It's this assigned person who focuses on placement of patients. And every morning we have a bed huddle at 8:45. It's a stand-up meeting where everyone comes from every department, including physicians, if we're in especially when we're in the winter. And we go around. We have this predictive model from IHI. I recommend where you anticipate the admissions. We often say in the ER that we know the patients are coming, we just don't know their names. Why aren't we planning for those beds in the morning that we're going to need on the evening shift? The nurses and our patient care coordinators predict discharges, and the main results we get from this is real ownership for patients who are waiting. Often the nursing managers from the floor will come down and round in the ER just if there's patients boarding or to apologize to them. We had this, it was a Kaizen event just to standardize the ED to floor report and prevent those calling back and forth. Frontline staff drove this process. They came up with a process that was not the one that I would have chosen, but it's one that everyone could agree on. And this is a picture of ER nurses and floor nurses. We're trying to figure out a way that's better for the patients. And this is kind of old, but you can see this showed all the wide variation we had in our time from ED to floor, and then we opened the bed center, we decreased the variation a bit, and then after we developed this time where there was the bed huddle and this no meeting zone where we're really working on it, we really standardized it so much on the right. We developed this rapid surgical unit. This came out of a winter summit. This was made in 6 weeks. And it decreased our length of stay. Again, everything's about decreasing length of stay for total joints, operative surgeries. And it looked pretty too, but it was done in 6 weeks. Can you advance for me? And you can see it's very protocol driven again. This is what for knees, appendectomies, maxillofacials, urology, bariatrics. Everybody's on the same page. They know exactly what to do. It's standardized as much as possible, again, about decreasing length of stay. This really saved us from boarding the first winter it was open. And even everything was thought about. This was put on the floor. These little squares are 10-foot blocks, so patients know beforehand how far they have to walk, what are their goals, where are they trying to get to. And we even have it that patients can visit there before the surgery, so they just everything's about the expectation. We're looking at OR smoothing now. We found our ER admissions surprisingly were even across the 7 days, but surgical flow was causing the bottlenecks. This is our first year of working on this, and this was my friend Chuck Noon did this from his company, but you can look at our OR admissions by day of the week, and Monday is our busiest ER volume, and you can see it's also our surgical volume, so that meant Mondays and Thursdays were just killer in the hospital. So now we've just shifted a couple blocks, and all of a sudden we have this smooth flow across the whole hospital. And now, but what do we do when there's just not enough of room? You guys are up in Maine, so you had already been hit, but this was when the influenza was hitting so bad, and we were sitting there in California, and this graph came out, and I was like, oh my God, here it comes, and what are we going to do because we're already full? So we don't have to be surprised every winter sucks, right? So we have to figure out what are we going to do and what are the plans and how do we all react so we aren't all worried and screaming and just trying to make room. We want to make it very predictable and standardized. So we did use the standardized overcrowding score, the NEDOC score it's called, but it doesn't really matter what it is. It's just any score that you can get that's a very objective way to look at overcrowding. So there's something called the CDOCs and there's something called the NEDOCs, but it's a reflection of the inpatient capacity, really, inpatient waiting. And we actually posted it on our webpage, and we kind of educated all the employees to look for this, and it helps them know that where we are, like they know it's normal. If it's in the red or black, maybe the clinics do a little more work to not send somebody to the emergency room. Maybe we look at our surgeries. Maybe we look at decreasing length of stay in some other ways. But it's everybody's on it. It's not just the ER. It's not just one or two people. The entire team of physicians and nursing working look at it every day. And the most important thing is that it's linked to the surge plan. So we went around to every department, everybody, and we got agreements on what they're going to do when we're in these critically overcrowded states. So if you can see on the right, if it's greater than 25 patients in the waiting room and more than a 2-hour waiting time, physicians meet to call in a backup MD. And we have the same thing. HBS, our medical people will come to the bed huddle. They may call in an extra physician. It's just the lab will send an extra phlebotomist. The transporter will come to the ER. So it's kind of a multidisciplinary approach to the surge, and it's not just one or two departments trying to lift everything. It's everybody working together. So our final truths are the longer they stay in our ER, the more work they are, or in the hospital, and the deeper they get from the front door, the longer they stay. So everything is about decreasing length of stay, creating very standardized processes, making it easier for patients and the employees who work there, and having fun while you do it. So we have this I'm really proud that we've developed this culture of patient-centered innovation and flow that we use here. And that's how we've gotten the results that we have. This is one of our nurses, just as a frontline nurse, who decided maybe one of her projects could decrease our wait time. So we got a whole pile of papers, and each one represents one of our busiest days, and we're doing timing studies. But look, that's a clerk, that's our head doctor, that's our charge nurses, and we're all working together thinking about that. And it led to this, 0 minutes. So thank you so much for letting me talk to you in Maine. And if you have any questions, please let me know, and please feel free to email me. I know that was kind of a breeze through 8 years of work, but I hope you got the general principles.
Karen, thank you so much. What wonderful information. Greatly appreciated. And so now I would encourage anybody who's on the line to type any questions that you have in the chat box, and I'd be happy to read those so that we can get some answers for you. I do have one question in regard to resources. If resources at our facility are low, would you anticipate that some of these solutions that you're recommending might be difficult to implement, and how would you make a recommendation to get beyond that?
You know, I've written so many business plans to get more resources, but I've had a lot of people say they can't do things because of resources. I think pretty often you can find low-hanging fruit that you can do without changing resources. So for instance, the low acuity area. And then what happened with that is then I got the credibility. I was able to show the return on investment for something I did with no more resources. Then they were much more likely to listen to me and give me the resources when I asked for it. So and again, I usually ask 30 times or more before I get something. But I usually would start with just doing a process that doesn't require additional resources. There's so much waste in medicine that I'm sure you can find them. And then you get that credibility you need as you move forward. Okay, great.
What about resistance to change? You had mentioned that that you had some people really hated the change in the beginning, and how did you get people on board with the team building and change the culture and combat some of the resistance that you faced?
Yeah, so I haven't found a single process that you don't have resistance to change, but I know in every place that you work, there's a few people that are the vocal minority that really hate change. So we try to invite at least not the entire team, but at least a few of them into our groups, into our flow groups. And then they're involved in the change, and so that helps too. Occasionally, I've just had to push through and just actually live in the place. And make sure that the system is followed. And then after a month, 30 days to 60 days, then it drops away because people see that it actually does work. But involving a whole group of frontline people in a change means that it's not just you leading from the top down. All of a sudden, it's this kind of movement that makes it a lot easier to deal with that resistance.
Okay, great. Can you provide any specific recommendations on how to get started with a flow project in a hospital?
Yeah, I think I would start. The first thing I would do is get a group together of a small group, but make sure it's that multidisciplinary team that I was talking about. And then I would brainstorm, and you have to kind of look at what are your bottlenecks. And so two things. First, look for the low-hanging fruit, something that you see that drives staff crazy but is easy to fix. So that's where I would start. That's your first project. For instance, our triage system was way too long and discombobulated, and it was much harder for the staff. So changing that kind of gave me a little bit of win. And then I would also do a brainstorming session and have everybody really sit down and write down all of the things that they think they want to work on, and then start quantifying which are the easiest, the hardest, kind of make a quadrant and see. And first start with the ones that are easy to implement and easy to do and don't require more resources, and then go on to the next ones. But you can also do a lot of calculations to figure out the bottleneck. So you want to figure out your bottleneck and what's causing the flow problems, and work on the bottlenecks too.
Oh, some good suggestions. Okay. Any other questions? We'll put it out there one more time. If anybody wants to ask a question, you can put it in the chat box. While we're waiting to see if we get any further questions, I'll just remind people that this presentation is being recorded and will be available on our member website along with the slides, so that you can reference them at a later date. We will not be holding a webinar in the month of November next month, since we have our large annual symposium. And again, any questions about registration for that, you can contact me at the number or email on your screen. In December, we are probably gearing up for a webinar on physician satisfaction and burnout, so that should be very interesting. You may want to mark your calendars to look out for something in December, and we'll certainly notify you of that, and we may add another webinar as well. Additionally, if you have any feedback or the specific webinars you'd like to see, please let us know. Again, my contact information is right there at the bottom of the screen. So I think it doesn't look like we have any other questions. And Dr. Murrell, thank you so very much for your robust information, and we just are very appreciative.
Yeah, good luck, everyone, and let me know if I can help in any way. Thank you, guys.
Okay, thanks. Have a great afternoon.
All right, you too. Bye.
All right, bye-bye.